Next, we have Dr. Nayana G. Her paper is on understanding strabismus and amblyopia in preterm children, its types and contributing factors.
A very good afternoon to one and all. I'll be presenting my study on understanding strabismus and amblyopia in preterm children, types and contributing factors. So, strabismus and amblyopia can be the common vision disorders that can have a significant impact on the life of preterm children. So, the previous studies has shown the prevalence of strabismus in preterm to be around 20 to 40%, while in term it was around 2 to 5%. And similarly, the prevalence of amblyopia was found to be around 10 to 15% in the preterm, while it was around 1 to 3% in the full term. So, our study was to study the types of strabismus and amblyopia in the children born preterm, now in the school-going age group, and to analyze the factors contributing to the development of squint, refractive errors, and amblyopia in these children. It was a retrospective study including 152 children, now in the age group of 5 to 9 years, who were born preterm. We have included children born less than 37 weeks, now in the age group of 5 to 9 years, presented to our pediatric ophthalmology clinic, and a complete medical record was available for review. We have excluded children with any history of ocular trauma or surgery. Any congenital anomalies like cataract or glaucoma were excluded. The factors we considered included factors associated with birth history like gestational age, birth weight, and NICU stay, postnatal factors like developmental delay or associated systemic conditions, especially neurological conditions, and the ROP related factors like presence or absence of ROP, stage, and the treatment taken for that. A detailed anterior segment evaluation was done, followed by an orthoptic evaluation, vision and cycloplegic refraction, and a posterior segment evaluation was done in all those cases. And the type of strabismus, refractive errors, and amblyopia was analyzed. The association of each of those factors with the development of squint and amblyopia was assessed with chi-square test, and the mean age of development of squint was also assessed. Coming to the results, among the 152 children aged between 5 to 9 years, the male is to female ratio was 1:1.2. Majority of the children came in the late preterm group between 32 to 36 weeks, and the birth weight majority came in the low birth weight group, and history of ROP was present in about 37.1% of the study population. The prevalence of strabismus was found to be 52.8%, among which intermittent exotropia was found to be the most common type, followed by accommodative esotropia. Amblyopia was present in 34.8% of the study population. Ametropic and anisometropic were found to be the commonest types. And coming to the refractive errors, astigmatism was the most common, followed by a combination of myopia and astigmatism and myopia. So, we did a chi-square test and found the association of each of the factors, and the development of strabismus was having a positive correlation with a p-value of less than 0.05 with gestational age, birth weight, the presence or absence of ROP, the associated developmental delay, and associated systemic conditions. So, amblyopia was found to be a significantly high in cases with severe ROP and also in cases which were treated with laser and intravitreal injections. There was no significant association between the severity or treatment taken for ROP and the occurrence of strabismus. And myopia was found to be significantly higher in the laser treated ROP cases. And we found esotropia to be more common in the early preterm, while intermittent exotropia was more common in the late preterms. The mean age of onset of strabismus was found to be 2.76, and for our surprise, about 38% of the cases, the onset of squint was before 1 year of age. About 28% of the cases, the parents noted squinting before 6 months of age. So, to conclude, a significant association between gestational age, birth weight, presence of ROP, and the prevalence of strabismus and amblyopia highlights the need for regular eye examination in the preterm children with these risk factors. The study's finding on the types of strabismus with esotropia more common in early preterm and intermittent exotropia in the late preterm can be used for targeted interventions. And considering the age of onset of strabismus, a regular orthoptic evaluation along with the cycloplegic refraction is recommended in these children in the preschool age group. So, what is already known? According to Vijayalakshmi et al., the existing guideline says if there is no ROP, the first examination should be done at 2 years. If the ROP, if it is not treated with laser, at 1 year the first examination and annually thereafter. If the ROP case was treated with laser, first examination at 3 months and every 3 to 4 months thereafter. So, according to this guidelines, many of the times we are getting children at 4 year or 5 years. They may be adding extra years from their this thing also. So, what we propose a new guideline. If there is any strabismus or nystagmus, the consultation should be immediate. If the child is not responding to lighter phases or if there is any features of CVI, immediate consultation should be done. And if the gestational age is less than 32 weeks, very low birth weight, history of developmental delay or ROP, if not treated with laser also, the first consultation should be done at 6 months. And in cases of ROP cases treated with laser, first consultation at 3 months. So instead of telling the children for a pediatric opinion at 1 year or 2 year, it is better to educate the parents about the warning signs of amblyopia, strabismus and all beforehand, so that they can have a earlier consultation before the amblyopia or strabismus or the suppression sets in, and we can help these children. These are my references. Thank you.
Did you include all the ROPs which were examined in your, or did you have any exclusions?
Any cases which was any surgeries or any cases with any congenital anomalies were excluded, ma'am. And also those children who are not in the follow-up or who are not having the complete medical records, we have excluded, ma'am.
Because from what your record looks like, then most of them at the most received only laser.
Intravitreal also, ma'am.
But I don't think more severe ROPs were included in this, who needed surgery or who were.
Yes, ma'am. If they are presenting to, this was done in the pediatric ophthalmology clinic. So,
Yes, but so I think you should
yes, ma'am.
mention that. I'm
Yes,
sure
ma'am.
those patients who are opaque, who have had lens weight, who have
Yes,
had
ma'am.
buccal are also coming to your
Yes,
clinic.
ma'am. Yes, yes, yes,
So
ma'am.
you should mention that in our exclusion.
Yes, ma'am.
You have taken you have really
Yeah.
excluded the all severe ROPs from there, right?
Yes, ma'am.
So I think that should be clearly mentioned.
Yes,
You have
ma'am.
excluded patients who could not be recorded vision because of CVI. You have excluded a whole lot of patients.
Yes, ma'am. No.
Yeah, so I think in your exclusions you should mention that. If
Yeah.
you have included only up to laser, who could be
I have
there is
included
a
like
whole
any.
lot of selection bias in this paper.
Yes, ma'am. I have included in the exclusion criteria. I have mentioned any ocular surgeries, ma'am. So I have considered up to lasers and intravitreal. All surgeries were excluded.